also sets up our next speaker very well, who is a colleague of yours at UCSF, Dr. Monica Gandhi, who is the director of the UCSF CFAR. She works out of San Francisco General Hospital. And she's going to take us into some details about health disparities and practical ways forward in terms of what we can do to reach these populations. Dr. Buchbinder just gave a hint of that, and Dr. Gandhi will finish that story for us. So welcome, Monica.
Thank you very much. I do think that, a lot of the innovations I'm going to talk about here are actually already were just summarized by Dr. Buchbinder, because I do think that the HIV program and the prevention program at the San Francisco DPH is leading the way in terms of trying to address these disparities. So I may go a little more quickly through that and think of some more creative ways to think about disparities using the long-acting injectables. So, I'm tasked to talk about these hard-to-reach populations. And Dr. Buchbinder really went over this already, but we just have data point after data point that's showing us that there are racial and ethnic minority differences in the uptake of PrEP. And, it's not just racial and ethnic minorities. We'll talk about later cisgender women, and we'll talk about older individuals as well. But this is data from 2018, but these disparities still exist. Of the new infections in 2018, 26% were in Black African Americans, and yet the uptake of PrEP is so much lower in that population and in Latinx populations as well. And if we look at in the disparities by gender identity, the same sort of pattern emerges that MSM are more aware of PrEP and also of higher rates of PrEP, not only initial uptake, but even along the continuum, starting PrEP, concurrently on PrEP, higher adherence, and not discontinuing PrEP. This is data from Alu here at CROI 2019. MSM have higher rates of all of those metrics of the HIV care continuum compared to transgender individuals and non-binary individuals. So there's work in that direction as well. And then in terms of, this is just more data that really shows that for trans men, so the data that I've just shown you is for trans women, but same with trans men, online survey, and these are slides that really came out of by the way, the HIV work that I think Dr. Scott and Buchbinder both on this call are doing. But an online survey of trans men also show that only 11% report being PrEP, even though 24.3% were PrEP candidates. And this was published a couple of years ago in JADES. So this is data that was compiled by the San Francisco DPH, and Susan had presented to you and presented at CROI a couple of years ago, that shows that still kind of PrEP candidates by race and ethnicity, we just continue to have these disparities. So African American, Latino, and Asian are less represented in our PrEP uptake, and all even over time than white individuals. So the problem is I can keep on presenting this kind of data to you, and here's one from Kaiser, the same idea, but it really is about sort of creative solutions, I think, instead of presenting data that shows this across multiple networks, including in San Francisco and including in across the Kaiser healthcare system, for example, in Northern California. So Dr. Buchbinder already alluded to this, but it isn't just San Francisco. There's really 12 projects that are participating in Project Pride, which is the CDC-funded 3-year demonstration project. And the idea of this entire project across these 12 jurisdictions are to increase PrEP among MSM of color and transgender persons, given the disparity data that I just showed you. And that enhancing data to care activities means that you use surveillance And then you use people who are that surveillance data to identify those who are at risk. That would include, for example, those with STDs, including people who access the healthcare system, and then try to relink them into HIV care if they're positive, and if they are people who don't have HIV, to link them into PrEP care, and to think of programs such as same-day PrEP, targeted PrEP outreach, things that are really creative that we've used in ART care. And I'm going to talk about that when we get to long-actings as well. And then these programs need to not just link people into care and into PrEP care, but they need to actually work on this in higher discontinuation rates among Black versus white patients, because there is the problem of initial uptake, and then there is the care continuum that leads to adherence, and then fundamentally HIV PrEP persistence. And we want that persistence to occur over times of risk. So I really, I feel like I'm really repeating some of the creativity about what Dr. Buckminer and Dr. Scott are presenting, but it really is, if you think about the barriers that are coming, that are the most significant barriers to being on PrEP in different disparate populations. One is cost. And so we now are in a situation where TDF FTC is completely generic. And we will talk about that when we think about same day PrEP. We at Ward 86, our plan is to have already purchased TDF FTC for our patient population. And now our next step is to figure out how to disseminate it in a same day program in the same way that we disseminated ART rapidly in our Rapid Start program. So we want rapid PrEP programs. We want HIV testing in a rapid way using an oral-based test right there on site. And then we want to send laboratory tests, but still, for example, like creatinine, but still starting the ART, the PrEP right there and then, given now that we in a low income clinic, at least at Ward 86, don't have that PrEP cost concern with the generic formulation of TDF FTC. That while we're getting patients on insurance, because a lot of patients present to us without insurance, can circumvent some of the problems before insurance is garnered. And then things about don't want to take a daily pill. Of course, we're going to talk about that and have been talked about at this meeting about long acting, and concerns about side effects, which I'll go over at least a little bit when we go over the older patient scenario with PrEP. So again, lots of creativity here occurring at San Francisco with these different SFDPH messaging that are looking and messaging and showing culturally appropriate pictures and flyers of people who we are trying to reach in the city. And this is really work, again, by some of the people talking on this call. And then Susan just talked about this, but really some of the good ideas are a pharmacy-led PrEP program, so that there's kind of circumventing the barriers of going to a medical clinic, youth-focused efforts. So Truvada Emergency Fund, which we have here at Ward 86, and we have already literally have our purchases of Truvada in stock, and youth PrEP navigation. Social media is incredibly how apparently people interact when they're young. And so working in different social media platforms, and metrics focused on priority population intake, which involves that surveillance data that DPHs have access to actually. And then we are really interested in express visits, just because rapid ART has been so successful in a safety net population at Ward 86. So our idea, and this is next, is again these same day visits to start pre-exposure prophylaxis, where we give people starter packs for their TDF FTC that we have purchased while we are working on insurance for more enduring coverage, and that is our plan. So in terms of the CDC guidance, it also doesn't yet. I think there's an incredibly important need to focus on cisgender women and older populations. And though CDC hasn't endorsed the 2-on-1 strategy yet, they are planning to. And IAS-USA, of course, that sponsors this meeting, had endorsed 2-on-1 quite a while ago. And so if you think about these populations, if we think kind of focusing on cisgender women, which is in our city a very underrepresented population in terms of PrEP uptake, then sometimes we have to move away from risk assessment, right? Because it really isn't about the risk often of yourself, but it is the risk of your partner. And risk assessment, we moved away actually for HIV testing. The original CDC document for HIV testing that was risk-based and turned to routine-based, was in 1996. So we really are in that edge now in 2021, moving away from risk assessment by asking people about their risks and just kind of more of a routinization of PrEP discussions. Because if you don't, have open-ended conversations where in your sexual histories, then you really may not just by making assumptions about someone know about different risks or just essentially sexual activity that can lead to fundamentally such a basic thing, lead to the need for PrEP. So this is, again, data from Hyman, but it's really a great way to think of the sexual history with Ps. So partners, practices, protection, past STI history and pregnancy, and the desire for it. So moving away from PrEP is for people at high risk for HIV to PrEP as a tool. And PrEP is a tool that can be used for anyone to take control of your sexual health. So that is, I feel like, we all remember the HIV testing shift that we all made, and it was so long ago. So we have to make that shift also in the setting of PrEP when we're trying to reach populations that have not yet uptaken PrEP. And this really applies to older individuals, right? Because older individuals often are there's assumptions made about sexual activity, about condom use. If pregnancy is not a concern later in life for women, then condom use definitely decreases, and aging and the need to get more people who are older living with HIV is really highlighted by the data from the 2018 CDC surveillance data that shows us that older people, of course, are at risk for HIV infection. But in older patients, we think about three things. Adherence is actually often better among older patients than younger patients, but then we have to remember about polypharmacy in older patients, and then TDF and FTC and TAF and TDF and TAF both have concerns about kidney function and bone density. And so thinking about those in older individuals, especially since we have novel and newer modalities that will come out once cabotegravir is approved for prevention, thinking about this in the meantime is really important. And so, this is a case where someone has come in who is older, 58, has hypertension. He has absolutely a need for PrEP, and his creatinine is 1.7. And so I'll let you, think for a minute about what you would do. Would you prescribe daily TDF FTC, or would you say, okay, well, I think that TAF is safer enough that I would do that for someone with renal function? Do you think that 211 TDF FTC will actually, he does have frequent sex partners, but will decrease our renal toxicities, which we don't really know yet? And, or should we tell him to use condoms? And this is a thought question for you, but, oh, wow, okay, why don't you actually vote? And there's music. So yes, I mean, I think that TAF FTC is safer for renal function. We don't have data on if 211 is, though it actually makes sense that it would, though someone with frequent sexual exposure may end up being on 211 about 4 doses a week anyway, by the IPRGay data. So it is, I completely agree that, that while we're waiting for our safer options, TAF FTC is definitely something to do. We just don't have 211 data. For example, on TAF FTC, which would be probably the way to get the minimum of TAF exposure, at least in plasma levels. And this is data that we collected using hair levels of antiretrovirals, but it still holds that really older people who are on TDF FTC regularly, so taking, at least by their hair levels, and this was modeled in the IPREX-OLE study, those who are taking 7 pills a week are more likely, especially if they start out with creatinine clearances that are borderline, like this patient here at 61. If they start out with borderline creatinine clearance and are adherent to medications 7 days a week, which is actually more likely to occur in older individuals, renal function actually decreases more in those who are older, baseline creatinine clearance that's less than 90, and take pills regularly. So you could extrapolate from this that if you take pills, the TDF FTC less often, that it looks like renal function, at least over time, doesn't decrease as often, doesn't decrease as much. But again, from the IPREG data 211, taking it less often, we are extrapolating from studies like this that seeing overall less tenofovir exposure is going to be better for renal health. So, and then here is someone who's a 50-year-old MSM who has sex with new partners. So again, an older patient, or by some definitions of older, with new partners approximately twice per month. And he doesn't want to take a daily pill because his sexual exposures are relatively infrequent, but he doesn't always use condoms. So what would you do? Would you, number one, encourage him to use condoms? No, his exposure is relatively low, so don't worry about PrEP. Encourage him to take daily PrEP. Have them start PrEP 7 days before sexual episodes, or is this the perfect case for 211? Which the CDC is about to endorse 211. Yeah, and so I think that's great. And you know, this is a kind of the perfect person. And if we go back to this idea of that taking, if you end up taking 2 to 3 pills over a week, you know, average 2 pills over a week, or 2 to 3 pills over a week, you can see that your renal function really appreciates that, at least as determined by long-term exposure measurements. So I think that's a great point. So, you know, Dr. Molina is you know, really the lead investigator on the IPREG. So I feel like I don't want to go through this impressive studies and the impressive IPREG open label extension studies so that we can get to our final point. But it really does lead to less exposure fundamentally of the TDF FTC, even with frequent sex and sex partners, as in the original IPREG study, about 4 doses a week. So that does end up leading to less overall exposure. And I think if we extrapolate from those hair levels, that can be a safer strategy, or the TAF FTC, which right now, of course, is not approved in cisgender women, for example. So we await, the CDC is going to endorse the 211 soon. IAS-USA guidelines did endorse it quite soon after the data came out from the IPREG study. And then where are we with women? Well, daily TAF FTC is absolutely being studied, but it's not here yet. It wasn't included in the Discover trial. Cisgender women were not included in that trial. So we don't have data for TAF FTC for vaginal exposures, and that is not included on the list of indications for daily TAF FTC. However, Gilead, which is performing a study of their long-acting agent, which is lenacapavir, for prevention in women in sub-Saharan Africa, also have a TAF FTC arm in that study, which is helpful, and we will get that data because there are other studies like Impact 2010 that have been very intriguing, just published in The Lancet by Shaheen Lockman as final author. But in pregnancy, there are some elements that look like it's safer to be on TAF FTC, at least for the fetus, than TDF FTC. And so if you expand the availability of pre-exposure prophylaxis, with TAF FTC, pregnancy is such a high risk time that I think it's going to be incredibly important for low income settings. So again, I've already said this, but 211 is not yet for cisgender women. That is also, again, if you want to keep their exposure down, that is also an important thing to study in cisgender women. It's really only studied in MSM to date. You do need daily TDF for having chronic hepatitis B. And there are, of course, planning and forgiveness issues with the 211 strategy, but having that plan when you know. Okay, so the reason I actually am turning to treatment for a minute in my last little bit is actually to extrapolate or make a larger point about intramuscular cabotegravir for prevention, which is the focus of this meeting. So I'm curious for you in this audience, have you started a patient on long-acting ART for treatment yet? And remember, it's only been out since May. So if you're still figuring it out, which is number 3, or yes or no, or you're waiting for even long-acting ART, those are all good questions, answers. This is just an opinion question, but I'm curious if you have started ART for long-acting treatment. Okay. And no, and I think that's excellent, is the highest one, because we are still figuring it out, actually. And I want to bring in some elements of the treatment aspects of cabotegravir to make some larger points about the use of IM cabotegravir, which of course is part of this, with Dr. Landowitz, part of this meeting. So again, I'm not going to go over the data because that's not the point I'm trying to make. You absolutely know the data about HPTN 083 and 084, comparing TDF-FTC to intramuscular cabotegravir every 8 weeks and finding superiority in both the HPTN 083 MSM transgender women study and in cisgender women, the 084 study. And the other thing that you very much know at this point is that there were failures in HPTN 083. And again, remember, cabotegravir is given every 8 weeks for prevention that evolved INSTI resistance. And so that does have implications for treatment, but there were 5 out of the 16 failures. One had an undetected HIV infection at baseline, and 2 were infected during lead-in, and then 2 were infected even despite on-time injections. But all of those 5 cases emerged in a way multiple resistance mutations, including to the rilpivirine, including to the cabotegravir component. These are all cabotegravir mutations, of course. Remember, E138 gets confusing because it looks like a rilpivirine mutation, but that is also an integrase gene mutation. And then if you look at Atlas 2M and which is the every 8 weeks for treatment, again, not the focus of this talk, but I wanted to remind you that we do have INSTI mutations that emerged there as well, more readily than in the 4 weeks administration of IM treatment. This is all the mutations at the table that puts together all the mutations, INSTI mutations that emerged. Just look at the second column in FLAIR, which was, of course, FLAIR was the treatment experienced every 4 weeks. Treatment naive. Atlas was treatment experienced every 4 weeks. Atlas 2M was going out from 4 weeks to 8 weeks for treatment administration. HPTN 083 I already told you about, and then the white is Atlas 4 weeks. And you can see that really it's this 8-week aspect that seems to, even with on-time injections, in certain patient participants, there's an emergence of INSTI resistance. And so what are the factors for development of CAB resistance, at least in the treatment trials? Because I want to remind us of this when we think about who are we going to be comfortable putting on every 8-week prevention or treatment. Was it being late for injections, which is, and we can actually bring up the slide. Was it having proviral rilpivirine mutations? Remember, these are the treatment trials. Was it having HIV clade B? Was it 816? Or was it having a high body mass index of 30? Or is it answers 1, 2, and 5, or 2, 4, and 5? And please vote. Okay, so the majority of you said 1, 2, and 5, being late for injections, proviral ripivirine resistance mutations, and body mass index of 30. You are actually right, except that it's 2, 4, and 5, meaning the BMI was true, and so was having proviral ripivirine resistance mutations. But this data from AIDS that was just published very recently, looking at the treatment trials, FLAIR Atlas and Atlas 2M, looked like the 3 major risk factors were having a HIV subtype of A1, presence of the proviral or ripivirine RAMs, and a higher BMI. So there's something about cabotegravir that maybe it distributes more in tissues with higher BMIs. So we have to remember that when we're going to turn towards cabotegravir for our prevention. We could extrapolate from treatment here. There is something about A1 which we don't have that subtype as the prominent one in the United States. We have clade B, but remember that with cabotegravir. And then of course, totally makes sense. If you had proviral ripivirine mutations that you didn't know about, you're going to be more likely to fail cabotegravir ripivirine for treatment. So the reason I bring up treatment is because we have really been waiting for long-acting ARV treatment, not just for the highly adherent, not just for what FLAIR and Atlas both looked at as the inclusion criteria in their trials, and what's in the package insert, which was kind of perfect patients in a way. They were all, the FLAIR, remember, was the naive trial, and you had to be virologically suppressed on a dolutegravir abacavir 3TC regimen for at least 16 weeks. Then you went over to an oral lead-in for 28 days of cabotegravir ripivirine, and then you got to start on your injectables, though there was a subset of participants who went direct to inject from dolutegravir 3TC abacavir and did fine. And then you had to kind of come in and, they really weren't 1 week past their regimen, at least in the 4-week trials. So sure, it's going to work for patients who are tired of taking oral pills and highly adherent, but what about the poorly adherent patients? Because who have other challenges to coming in, other challenges to taking oral pills, because this is going to extrapolate to using IM cabotegravir every 8 weeks when it gets approved for prevention. If we're interested in older patients because of side effects, are we interested in those who have challenges to coming in? And so I want to tell you about a treatment case, but I only have a minute or so more. So I'm not going to actually go through the case, but I'm going to tell you, even though this is a very interesting case, but this case is someone who I had in my clinic population who we ended up deciding to start intramuscular every 4 weeks treatment for, and he didn't fit any of the criteria of FLAIR and Atlas. He had a high viral load before he started of over 500,000. He had a CD4 count of 18. He had actually 1 cabotegravir mutation and 155, but he absolutely could not take oral pills for a variety of reasons, including methamphetamine. So I actually did start him on IM cabotegravir and ripivirine, and very poorly adherent otherwise, have multiple challenges. He's now on his 7th dose, and he is doing great. And I literally saw him in clinic yesterday, and he is feeling over the moon. 7th dose, perpetually came down from higher than 5,000 to less than 30. And has had 3 viral loads that's less than 30. So why does that have clinical relevance for intramuscular cabotegravir? I think that we should be brave enough to try it in patients who really, as long as they can come in every 8 weeks for their injection, that we should be brave enough to try it. We have done this with our treatments. Of course, in treatment, we absolutely mandate that they have to demonstrate that they come in every 4 weeks. That is our only inclusion criteria for our pilot project at Ward 86 for the use of IM cabotegravir ripivirine. So I hope that we're going to be able to use this as a major aspect for people with concomitant challenges in life. And then I will not actually talk about the newer long-acting ones that are coming because they're not here yet, but they are going to also be profoundly exciting for our disparate populations. Thank you.